right, everyone. So today's lecture is going to be over throat and oropharyngeal disorders. And this is the last part of our EENT series. After this, then we have exam review, we take our test, and we all ace it. Sound good? Yes. Here are our learning objectives as usual. And here's our outline. So we're going to start with a little bit about teeth and gums. We're going to move on to the mouth and throat area, talk about some salivary disorders, trauma, and some other disorders. So, as we all know, we're PAs, or we will be PAs, but we are not dentists, but we do deal with a lot of mouth issues. One, because dental care is quite expensive, especially for the uninsured. So if we are working in urgent care or a family practice or maybe ER, we are going to see quite a few oropharyngeal disorders because a lot of these patients don't have anywhere else to turn. So let's move on. Like I said, we'll see a lot of teeth and gum complaints regularly. I can tell you, having worked in ER, I would see at least one toothache every single shift. I mean, it's just something that you see very often. Gingivitis don't see as much, but of course gingivitis is a precursor to problems with the teeth and gums. Dental caries also the same thing. I mean, patients don't really come in for a cavity, but after the cavity sits in for a while, can cause infections, and this is what we see most often, is dental infections that cause pain and abscess formation. So what we see is accumulation of plaque. You can also get gingival erythema or swelling. They also are friable, so you just gently touch them. They bleed, swollen, bad breath. And then later, of course, after the chronic gingivitis, you can get wearing away of the gum line, receding, and then eventually tooth loss if there's enough degeneration of the gingiva. You really want to refer to the dentist. We're putting a Band-Aid on a bleeder for them. We're not fixing their teeth. We're just fixing the pain or helping with the pain, but we're certainly not going to do what a dentist can do. So I always educate my patients that even if I'm putting a Band-Aid on their problem, I'm not fixing it. Swelling, of course, on physical exam, you'll notice. Every patient should have routine dental visits at least once or twice a year, proper brushing, flossing, and I mean, you should be counseling your patients on increased risk of cardiovascular events because of poor dentition. Now, those are bad, but this is bad. This is called trench mouth. And you can see it in patients with underlying disease, malnourished patients. And these patients get, essentially necrotizing to the gum teeth area. You get these punched out appearances. The gums are worn away, very red, ulcerated, and they have really bad breath, fever, lymphadenopathy, malaise. So you have to fix what's causing the problem to begin with. You can also have them swish with Parotitis, which is a swish and spit, and you can use oral antibiotics if needed. And they obviously are going to need a major dental follow-up. So cavities are pretty common, although I don't really see patients that often with just cavities that come to the ER. They can cause pain early in the process, which is why we do so much routine care in dentistry. They can be asymptomatic. Sometimes you can actually see the dental carie. Other times you see it more on x-ray. They can become soft, the teeth. And because you have this opening in the tooth, bacteria can get in and cause dental abscesses, which is why I usually see patients come to the ER. As far as exams you're going to look, you can ask the patient to point to the tooth that hurts the most, and you look on that tooth more in depth. And of course, we're going to refer to the dentist for repair. Sometimes they can repair the cavity, place a filling, Other times they have to do root canals and other things. In the meantime, really the standard of care in a general practice clinic is to provide antibiotics if there is signs of infection, and non-narcotic pain medication, because these patients with chronic dental issues can become hooked on painkillers if we give them high dose or narcotic pain medication. So like I mentioned before, dental abscesses, combination of kind of different flora within the mouth, especially anaerobic, causes redness and swelling, fluctuance along the gum line, toothache. These patients can be sensitive to different temperatures, especially heat with drinking hot liquids. You can also get signs of infection like nausea, vomiting, chills, fever. On examination, really it's a clinical diagnosis. We don't really do x-rays or blood cultures in the ER unless we feel like the abscess kind of spread to other areas other than periapical. And on exam, you see the abscess. You can palpate it. It's usually very fluctuant. You can also see associated facial swelling, and you might even notice a break or a cavity within the tooth. On these, if I see these in my emergency department, I will place a dental block for anesthesia, and I will do an incision and drainage of the abscess and place the patient on oral antibiotics, usually something like penicillin or amoxicillin, and refer them to the dentist. Because there's an obvious issue that's causing the dental abscess, so you're just helping the patient with the abscess, and they need to have the tooth assessed. All right, so let's move on to some more issues with the mouth and the throat. First up, we have Aphthous ulcers. So Aphthous ulcers, like a lot of folks have had, I know I've had them before, are commonly referred to as canker sores, the little blisters within the mouth. And they can be usually kind of a prodrome of kind of this burning or prickly, tingly sensation within the oral mucosa, and then afterwards out pops a little ulceration. The vast majority of these are benign, self-limited, and we just treat them symptomatically. There's really no specific treatment for them. As mentioned in this presentation, the etiology is not always clear, but there is some association with the human herpes virus 6. You should keep an eye on how often these patients are getting these ulcers, if there's multiple or just one, and then thinking a little bit about some of the other things that can cause them, aside from just the idiopathic aphthous ulcer, like certain autoimmune conditions, cancer, HIV, herpes, IBD, like Crohn's disease, where you can get ulcers in the mouth. So the presentation is going to be a painful, round, shallow ulcer, and the filling of the ulcer is usually kind of a yellowish gray with a red halo around it. And it's usually present on the non-keratinized mucosa, so in and along the gum line, in the buccal mucosa, on the tongue. And not always, but you can have repeated occurrences, and there is some loose association with stress. For physical exam, you look at the tongue, you'll get the oral mucosa, and that's how you can see that there is one. Patient will complain of pain usually. If you notice that a lesion has not resolved in 3 weeks or more, or if you're getting them with any frequency, then you should have this area biopsied. So treatment really just depends on the duration of symptoms. Most of the treatment is geared towards symptomatic relief. So what we tend to use is, number one, avoiding oral trauma or acidic foods. I know that for me personally, when I eat pineapple, it's a very acidic fruit, I tend to get these little ulcers on my tongue or inside of my mouth. So you can avoid that. Then right after that, there's what we use a lot in the ER is a magic mouthwash, which has a combination of magnesium hydroxide, Benadryl, and you kind of swish it around in the mouth and spit it out, and it can numbs the inside of the mouth. Another one is viscous lidocaine, can do the same. In little kids that have at least one or sometimes more, then we can want to be careful to prevent dehydration, because a lot of times when they have these ulcers, they won't want to eat or drink anything, and that can be more concerning than just the ulcer itself. And then, of course, if you're getting these recurrently or they're not resolving, then we want to refer to the specialist for something underlying that's causing them. Next up is Candidiasis. In your OB-GYN module, you probably talked about vaginal candidiasis. In dermatology, you probably talked about intertrigo or skin rash candidiasis. And in this case, we're talking about oral candidiasis or thrush. And this infection it's caused by Candida albicans, the yeast that we have naturally within our GI tract, and occasionally usually because of immunocompromised states or use of antibiotics, we can have an overgrowth of the Candida and can cause this thrush. We see it a lot in, like I said, immunocompromised diabetic patients, and then in infants, because one, the infants haven't quite established their natural flora yet. They also have kind of always in a wet, moist environment with nursing and having things in their mouth. They're also a bit immunocompromised. So for clinical presentation, patients have kind of a pain or discomfort within the oral mucosa, the tongue. You might see some whitish patches on the tongue and buccal mucosa, and also on the palate. And it's usually uncomfortable or painful. So on physical exam, like we said, we see a white patch, and what's important to note for this white patch is that it can be scraped off. So you can take a tongue depressor and scrape that white, and you will see a patch that's scraped off, sort of like here, where you see it can be scraped off. And once you scratch off, the area will be a little friable. You'll see kind of redness throughout the oral mucosa. The diagnosis is vastly clinical. However, you can do KOH preps, wet preps, biopsies if needed. As far as treatment, so first-time patients with mild thrush, you can use a clotrimazole troche, which are like little lozenge kind of things. You can use, of course, little babies can't tolerate those, so we would use nystatin oral drops. And what I use is I have them kind of place a few drops within the mouth and then kind of paint it on with a cotton swab applicator. Also, we want to clean or sterilize any of the nipples or anything that the patient puts in their mouth, pacifiers, bottles, and things, to make sure that they don't re-inoculate. There's also a nystatin powder for denture wearers. Systemically, you can give fluconazole, but typically we use that for either recurrent disease or severe disease, and especially if the esophagus is involved. Now, if the patient is immunocompromised, they have severe infection, amphotericin B can be given, but these are for very specific targeted cases. So looking at deep neck infections, if we remember back to the anatomy, there are many different spaces in the deep neck that are kind of planed off by different fascial planes, and we can get infections in kind of any one of these fascial planes, and they can cause symptoms of infection, including swelling, pus formation, fever, and toxicity. So most commonly they come from some sort of issue like a dental abscess, tonsillar abscess, middle ear sinuses, as we know that everything's all kind of connected in the back of the nose and throat. Depending on where this abscess is, can actually be life-threatening. As you can imagine, it can kind of cause difficulty with breathing. And there are a lot of different spaces, like we mentioned before. These are some of them within the deep neck. And like I mentioned before, some of the symptoms in them include fever, toxicity, erythema, swelling, fluctuance, difficulty breathing sometimes, swallowing. In the notes for this slide, you can see some of the different spaces and where they're found. Here what we see in this case looks like what's called a Ludwig's angina, which is in the submandibular space, usually stemming from a dental abscess. So depending on where the infection is, you'll see kind of a constellation of these symptoms, including sore throat, trismus, which is kind of the inability to open the mouth, the jaw kind of gets locked shut. Also dysphagia, trouble swallowing and pain with swallowing. If the airway starts being blocked, you might hear stridor or dyspnea, hoarseness. And then as the infection progresses, you can have more systemic symptoms like fever, chills. And then, of course, as that abscess or area of infection grows, you might see kind of more external swelling or bulging. So on diagnosis, you have a suspect that there's an infection based on clinical presentation. However, the imaging of choice is usually a CT, a soft tissue neck. And then there are some other limited exams you can do, including MRI and plain radiography. But I use CTs mostly in the ER when I suspect some sort of neck infection. You can see these are all the different spaces here. One that I see often tested is this retropharyngeal space. And so this is what we see here is this swelling in the prevertebral area, and this kind of, you can see, is starting to pinch on the airway, and patients can have trouble with breathing and swallowing. And I see this a lot in pediatric population. I did see one time a retropharyngeal abscess in an Asian woman. She had eaten some Asian food and had thought that maybe she ate it while it was too hot and it burned the back of her throat. So now she was having trouble and pain with swallowing, and she was, having some trismus, having trouble opening her mouth. And it was a very interesting picture. She had low-grade fever as well, but I couldn't really get a good exam of the back of her throat to see what it could have been. So in her case, because of her symptoms and her fever, I did a CT soft tissue neck, and she ended up having a retropharyngeal abscess and had to be admitted to the hospital. Also seen retropharyngeal abscess in pediatric cases where they complain of neck pain and they don't really move their neck very much. They have trismus and some stridor. I've seen that before. It is kind of scary, and they need to be their airway needs to be protected, and the abscess needs to be dealt with urgently. So one of the more common deep space infections is strep viridans. If you have a large fluid collection in the retropharyngeal area or anything in that space, they might have to be surgically drained or aspirated. From our standpoint, we need to place the patient on antibiotic treatment, covering kind of a multitude of different pathogens. And then that therapy, depending on where it is, should be continued for at least 2 to 3 weeks. It can be a little challenging to completely dissolve the infection. So epiglottitis is a blast from the past. Remember, we had covered it back in the day when we covered pulmonology. Now, technically, the epiglottis is kind of in the EENT area, the T of the EENT, but because it causes significant trouble breathing, I did cover it back in pulmonology. As a recap, we know that the infection is most commonly caused by H. flu, and for this reason, we don't see it nearly as often because of the H. flu vaccine that we give our children. It causes infection of the epiglottis, which is that piece of cartilaginous tissue with mucosa on top of it that sits in the back of our throat and covers our airway when we swallow. We see infections in children that are unvaccinated as well as diabetic patients, and the etiology can be both viral and bacterial. Nowadays, we see it more commonly in adults. As I mentioned way back when, the only case I've ever seen in real life was a middle to elderly aged woman in the ER. So think about the 3Ds: drooling, dysphagia, and distress. Patients are sick, usually the kids. They will be placed in a sniffing position, or their neck will be kind of stretched forward. They also present with stridor, fever, drooling, and toxicity. Here in this patient, we see tripoding, where the patient is kind of leaning on there. Remember, one of the major things they like to test on is about agitating the patient. If you have a young patient, do not agitate them. Do not try to start an IV or do a really intense physical exam. Most important thing is to stabilize the patient and stabilize their airway. All right. So we diagnose a patient with this clinically. However, you can get a plain film x-ray, the lateral view, looking for what's called the thumbprint sign. CT is also a good way to diagnose if the patient is stable. That is the way that I diagnosed the one patient that I've had with epiglottitis. You can do direct visualization. However, I would not advise that for pediatric cases because the stress of the procedure can cause them to completely block off their airway. Again, we want to secure the airway. We want to find someone that is a specialist in difficult airways and admit them for observation in the ICU with humidified oxygen, IV antibiotics, and steroids. So let's talk briefly about herpes simplex. We've talked a little bit about herpes when we talked about the eye, because we mentioned that both herpes simplex and herpes zoster ophthalmicus can affect the eye in different ways. So herpes simplex, we also talked about back in dermatology. It is a viral infection, whereas HSV1 generally infects the lip area and the face. HSV2 generally affects the groin, the genitalia. And unfortunately, after we are inoculated with this, many times you have an established lifelong latency where you can have interval episodes and asymptomatic shedding. So HSV infects 40 to 80% of the U.S. population and 60 to 85% by the age of 60, meaning that there is a lot of HSV in our community. Generally speaking, HSV1 likes the lip and the face, whereas HSV prefers the genital region. However, they can mix and mingle. Clinically, how do they present? You get usually little vesicles or a blister that a lot of patients term as a fever blister, with pain and burning around the oral mucosa. You can also have it within the oral mucosa and have ulcerations. Pharyngitis you can also get because of it. Many times on physical exam, you'll actually see those little vesicles or ulcerations depending on the progression of the illness. And in the perioral area, or HSV2 in the genital region, the diagnosis is clinical in most cases. And treatment, we can treat with, of course, the conservative management, antipyretics, analgesia, IV hydration if the patient is not able to take PO because of the pain intraorally. For the first episode, we want to give an oral acyclovir. And we want to start this medication within the first 72 hours if we are going to administer it. We can also give some of the other ones, although they are a bit more expensive, like the valcyclovir. For recurrent episodes, we also treat, but for less period of time to kind of try to get it under control. And there's also suppressive therapy for those that get recurrent episodes. Here's a couple quick charts comparing and contrasting herpes simplex from zoster, especially from the sense of eye infection and kind of what each causes. So remember, herpes zoster is the varicella zoster virus, not herpes simplex, and it attacks one specific nerve root, and you can have latent presentation of the disease. Usually reactivation is pretty rare, but you can get it, and it usually like we said, it does come up on a dermatome, although you can get it in different dermatomes each time it recurs. Postherpetic neuralgia is more common, and remember, herpes zoster causes herpes zoster ophthalmicus. Now, herpes simplex, on the other hand, can attack kind of any one of those little dermatomes, and it is more common to recur, and the infected dermatome is usually small, so like a single neuron. We also see very rarely postherpetic neuralgia in this herpes simplex. And so you can kind of see the difference here, comparing and contrasting. Also remember that herpes zoster tends to be more in the elderly population, whereas simplex can be kind of throughout the lifespan. All right, moving on to laryngitis. So laryngitis is an inflammation of the larynx, which is usually termed the voice box area. And it can be as a result of generally a viral illness. It can also be bacterial, but it's not as common. You can also get problems with laryngitis due to overuse, such as singers or people that are yelling all the time. And you can get chronic changes within the voice, having hoarseness acute changes in the voice with decreased volume, hoarseness, and so that's characteristic of laryngitis, having that hoarseness or loss of voice. Most commonly, like we mentioned, it's associated with viral infections like adenovirus and some of the other ones here, but it could also be bacterial, not as common. You can get it from squamous cell carcinoma. If you have a patient that has persistent hoarseness greater than 2 weeks, you should look into something more than just a viral laryngitis. And you can also get splashing up of GI contents like acid, and that can cause laryngitis. So hoarseness is the hallmark symptom of laryngitis. If in our vignettes we see a hoarseness, we should be thinking that kind of at the top of our differential. It's usually not as painful as like a pharyngitis. It's usually just hoarseness. Sometimes some difficulty swallowing, runny nose, fever, and then often associated with, since viral, upper respiratory symptoms. And we should remember that if it lasts more than 2 weeks, that's not likely a virus. It's likely something else. So we should have that evaluated. On physical exam, if we can take a look back there, we might see some pharyngeal erythema. Unless we have a specialized camera, we're not going to be able to see the voice box itself and look at that area. But we want to look in and around that area for vesicles, erythema, pus drainage. And then we can also check for lymphadenopathy. Now, like we said before, we base our diagnosis mainly on clinical findings. However, if we have a patient that has longer lasting, they can do a laryngoscope where they go in and look at the vocal cords themselves. As far as treatment, most of the time, especially for self-limited viral illnesses or overuse, we will do symptomatic treatment, including things like cough suppressants, voice rests, steam, hot teas, and things like that. And then, of course, avoiding the stress. So avoiding singing, shouting, because it can make these worse. If it is bacterial, we can give something like erythromycin or cefuroxime or augmentin. If we have other things like, let's say, GERD that's the precipitant, then we can treat that. And then a lot of times we give patients steroids, especially injections, to kind of speed along the recovery process. All right, so next up we're going to talk about a peritonsillar abscess. Now, this is something that we see with some regularity in the emergency department. We have a swelling in the area up here in the peritonsillar area. The word, it's also termed a Quincy or a Quincy's abscess. And I looked it up because I was curious where that came from. It kind of stems back all the way to meaning kind of like a dog, like to strangle a dog. I know that's kind of weird. That's where that name kind of comes from. And it's really a result of the infection through the tonsillar capsule. So you have neighboring pharyngitis or infection that infringes into the abscess, into the peritonsillar area. And a lot of times it involves multiple bacteria, including strep and staph, other anaerobes and things that can cause this type of abscess. And then you can also get like a Bacteroides as an anaerobic pathogen. So what we see, these are some really neat pictures. We look in the back of the throat, we see the uvula is displaced. Okay, you can see that the uvula is displaced this way. And we tend to see kind of a shininess at the posterior pharynx. This all area is very shiny. And so this here is shiny, and you can see the uvula is pushed over this way. Same thing here. But the tonsils and everything are red and inflamed as well. So patients present with sore throat, pain when swallowing, same thing. Trismus, because a lot of times that throat infection can make it difficult for the patient to open their mouth. We see uvular deviation or deviation of the soft palate. Patients have a hot potato voice. So hot potato voice really to me is just muffled. And it sounds like if someone's eating hot food, and they have that in the back of their throat. Other symptoms, less specific, fever, odynophagia, headache, malaise. On physical exam, you're going to see the abscess, or it might be even hard to see because the patient can't always open their mouth well. How we diagnose this, we use CT, soft tissue neck, usually with IV contrast, to visualize the infection and look for abscess, how big the fluid collection is, so that we know if we can actually get some fluid out if we do an aspiration. So the treatment involves aspiration or incision and drainage. As you can see here in this picture, what we usually use is a syringe on a spinal needle. So we get the spinal needle and we cut a little tip off of the cover of the needle so that only a little bit of the needle is exposed. And we stick that in the back of the throat. This is actually a blade for intubation. We can use that. We stick it back there and we suck out some of the pus that's back there, as well as placing the patient on antibiotics and steroids. If it's severe and they're having trouble with breathing or swallowing, then we keep them inpatient and admit them to the hospital. The one thing we need to be careful about when we do these drainages is the internal carotid artery that runs kind of back behind this area. So we have to be careful not to hit it. And that's one of the reasons why we keep that cap on and only expose a little bit of the needle. So here's our med comic on peritonsillar abscess. Mr. Potato Head has the hot potato voice. I really like these. Pharyngitis. So pharyngitis is one of the most common chief complaints, especially in pediatrics, family practice. I see it tons in the ER, urgent care. And pharyngitis really just means, again, inflammation or infection of the pharynx. And sore throat is super common. And there are different types of pharyngitis. The most common type is going to be like a generalized viral pharyngitis associated with upper respiratory type infection. Then we see strep throat, right, for bacterial pharyngitis. And fungal pharyngitis is very uncommon. Like we mentioned, viral more than bacterial, but they can both happen. And it's really important to diagnose strep throat because of the problems of complications post strep. Okay. So let's talk about strep throat first. So bacterial pharyngitis is most of the time caused by this group A strep. There is use of what we call the center criteria, which looks at certain things, certain physical exam findings and symptoms that we put together to decide if the patient is truly at risk of having strep throat. Because again, we see a lot of patients that come in with pharyngitis, and not all of them have strep throat, so we don't want to overuse antibiotics if unnecessary. However, we want to treat every case of group A strep. Really, the center criteria just helps you decide whether or not you need to get a strep test. Then you also want to consider gonorrheal pharyngitis. However, it's not nearly as common. It would be patients in vignettes with recent sexual encounters or non-resolving pharyngitis. So how do these patients present? Fever, sore throat, absence of a cough is pathognomonic for strep throat. You're going to often see tonsils that are swollen, red, with a yellowish or white exudate, as well as cervical adenopathy, namely more anterior cervical lymphadenopathy. Again, the center criteria is how we diagnose. So you want to have all these different criteria. So you want to have no cough. You want to have exudates on the tonsils, fever, cervical lymphadenopathy. And if you do, like I said, if you do have a cough or hoarseness or things, that's not as suggestive of strep. If you have 3 out of 4, you can get a rapid strep test. And if it's negative, you should still get the throat culture, because if it is positive, you still need to treat the patient. So here are the center criteria as well as their calculations. Now there are center criteria and the modified center criteria, and really the main difference is whether or not the score. There's like an option in here to do some other testing options. So we add the points up. And of course, there's no longer a recommended empiric treatment for strep based on symptoms alone. We always want to get a test to back it up. When we do our cases, we will work through using the center criteria so that we can get a better handle on how to assess those. The main important thing is to remember the different criteria that we use. So how do we treat strep throat? Strep throat is treated with intramuscular. It can be intramuscular penicillin G. We give 1.2 million units. Same thing we give for like syphilis, except we give more for that. If we have access to it. Now, I don't know if any of y'all have ever seen this medication, but it's literally like giving a shot of Elmer's glue. It's super thick and it can be quite uncomfortable. However, for patients that don't like to take antibiotics or medication in pill form, this is a quicker, easier fix for the patient. Otherwise, we can give the patient penicillin. PenVK is what we usually give, although you have to take that several times a day. Another alternative would be amoxicillin or cefuroxime. For those that are pen allergic, you can also give an erythromycin or azithromycin. And remember, we want to have these patients complete their therapy to try to prevent scarlet fever and the like. So viral pharyngitis is a little different. Now, when we speak of viral pharyngitis, there are many different types of viruses that can cause pharyngitis. most commonly adenovirus that we saw back when we saw conjunctivitis. Other things that can cause viral pharyngitis are the flu, herpes, and then another that's kind of in its own class is Epstein-Barr virus, or mono, the kissing disease. And we have to remind ourselves that that also is a viral pharyngitis. So when it is caused by Epstein-Barr virus, patients are usually super fatigued, very drained of their energy, sore throat, and then they can also develop splenomegaly. We want to not give these patients amoxicillin or things like that because they can get a rash with the penicillins. We can test them with a monospot test, which is a blood test, and we have to have patients on a trauma precaution, so no contact sports for a period of time after the infection to limit trauma to the spleen and splenic rupture. So these patients present very similarly and sometimes can be difficult to differentiate between like mono and strep throat, but we tend to see sore throat, fever. We can have some conjunctivitis, especially like with adenovirus, other URI symptoms. If it is mononucleosis, we tend to see posterior cervical lymphadenopathy. On exam, we see erythematous pharynx with or without exudate. If it is straight viral, like adenovirus, we see no exudate, but sometimes mono can have exudate. You want to also make sure to palpate the spleen and perform a lymph node examination. If mono suspected, you should perform a monospot test. A lot of things in the history would be like a new girlfriend, kissing, sharing of drinks with someone that was positive. And then center criteria, if it's met, we should do a rapid strep test as well to rule that out. So if it is just plain old viral pharyngitis, then it's really symptomatic care. So here's that posterior cervical lymphadenopathy back there. For mono, you want to avoid contact sports. You can give some steroids, but we also want to avoid antibiotics for Epstein-Barr virus. You can restart physical activity or contact sports 3 weeks from the symptom onset if the patient is improving. And then that's for non-contact sports, and for contact sports should be at least 4 weeks after the onset of illness. So make sure that if you diagnose this, that you let the patient know that they are not clear to go back to sports until they are cleared by their provider. Fungal pharyngitis is uncommon. It's kind of like the in-between between oral thrush and esophagitis, but we see it in patients that are immunocompromised, as well as those that use like inhaled steroids, such as like Advair or other steroids for asthma. And so you should counsel your patients to rinse their mouth after they use those steroids. I use an oral steroid daily, an inhaled steroid, and I always do it right before I brush my teeth to try to limit the potential onset of an infection like this. Patients also complain similarly to viral and bacterial in that they have sore throat, dysphagia. They tend to have more of this kind of cheesy white patch, different patches on the back of the throat. If you see this in a seeming otherwise young healthy patient, you should look for some sort of immunocompromised state. Again, we can use those clotrimazole troches we talked about before. There's also miconazole, nystatin, and fluconazole in patients that are immunocompromised. All right, now this would be a good time to take a quick break if you need one. We are more than halfway done with this presentation, but if you need to take a break, get up, stretch your legs, and come right back. All right, next up we're going to talk about salivary gland and duct disorders. We're going to talk about Sialadenitis, Sialolithiasis, and Parotitis. So Sialadenitis is an infection of the salivary gland. We have three different salivary glands. We have the parotid gland, we have the submandibular gland, and we have the sublingual gland. And so any type of infection of the gland, usually precipitated by Sialolithiasis, which like we've seen before, stands for stone, within the salivary gland, or sometimes with gland hyposecretion. It can get kind of a dry gland and infection. We can also get parotid or submandibular gland infections by the stone or blockage of the ducts. It creates kind of a stagnancy of flow, and that can cause infection. Most common pathogen is Staph aureus, and you also see it associated with Sjogren's syndrome because they tend to have kind of a dry area. So in Sialadenitis, which is an infection of the gland, we see swelling. The ductal opening might be tender and red. You might get swelling and pain, especially after eating, which is because that's when these glands are stimulated to produce saliva. And you can see it in patients that are dehydrated or that have chronic illness. If you look within the mouth where the ducts drain, you can see some purulent drainage. And then you get kind of the same non-specific symptoms, including low-grade fever, malaise, headache, myalgias. On physical exam, you'll often see swelling of the affected gland, sometimes associated with redness and tenderness. And then when you look inside the mouth, you might see either a little stone or pus drainage from the exit points of the ducts. The diagnosis is generally made with CT. However, you can also use ultrasound and MRI. If pus can be expressed, you can also send that pus for gram stain and culture to know what bacteria we're dealing with. For treatment for these infections is with IV antibiotics, and those that are effective against Staph aureus, like dicloxacillin, that's the PO, cephalosporins, clindamycin are things that can help with that as well. And if you have a patient that is in an area where there is MRSA prevalent, then you should also cover with FANC to cover for the MRSA. If we have just kind of a local inflammation and not quite a bad infection, you can also add on the sialagogues, which stimulate saliva production. So they're like lemon juice or lemon drops or things like that trigger saliva flow, which helps clear the infection that you have. Warm compresses, gland massage, good oral hygiene are also important. And then abscesses, if you have an abscess that shows up on CT, those do require drainage by surgeon. Sialolithiasis, on the other hand, is a stone within the duct. So these stones are often comprised of calcium salts, and the problem, just like you have stones that block the ureter or the kidney tract, or stones that block the gallbladder tract, these stones block the salivary tract, and they cause problems with obstruction of the salivary glands, pain, swelling, and then sometimes infection. The most common area to get a stone is within Horton's duct, which is also called the submandibular gland duct. And then Stenson's, which leads from the parotid or the parotid duct, also can get stones. Patients will oftentimes present with a postprandial pain and swelling, meaning that they start eating And then once their saliva starts being produced and kind of blocked by the stone, they get swelling on the unilateral side on the same side of the swelling of the stone, and they get pain. So clinical presentation: postprandial salivary gland pain and swelling. Swelling of the gland on physical exam. And then clinical diagnosis is usually adequate, but if you're concerned or you really want to see what's going on, you can get a CT or ultrasound. Most stones pass spontaneously. If you use sialagogues like the lemon drops or things, manual expression, but some require removal or via lithotripsy or endoscopic surgery. A lot of times we give antibiotics in conjunction to help reduce the likelihood of infection associated with the stones, and then oral hydration, and then sometimes might, like we said, might require surgical removal. Parotitis is inflammation specifically of the parotid gland. Now, Sialadentitis can be any of the glands. Parotitis is just the parotid gland. And the most common, or one of the most common cause of problems with the parotid gland is dehydration. It can occur especially in the elderly or those that are not eating or drinking much after surgery. You can also get bacterial parotitis via Staph aureus, similar to the other types of gland infections. Also, it's associated with mumps, so you can get the same swelling on the glands and with mumps. And then other viruses like the flu, parainfluenza, Epstein-Barr, all of those can cause parotitis as well. Also, autoimmune parotitis you can get from like things like Sjogren's and sarcoidosis. You can also get parotitis from Sialolithiasis. So when you have parotitis, many times you often have the symptoms of fever and chills, preauricular, where the parotid gland is, mandibular pain, swelling, can have trismus, and then purulent discharge. So the duct, Stenton's duct, empties in the back of the buccal mucosa back here, so you sometimes will see some pus drainage from there. You can send that sample for a gram stain and culture. You can get ultrasound, CT scan, CBCs, and things like that. Also, you can look for IgM against mumps if you think that's what it might be. Treatment depends on labs. Are they well hydrated? Do they have Sjogren's? Do they have an infection? We treat with IV antibiotics most of the time. And if it is viral, like the mumps, and it's self-limited, we do a lot of hydration, rest, and then give the MMR vaccines to prevent that. Dental trauma. Well, these pictures say 1,000 words. And again, we're not dentists, but oftentimes we will see a question or two on the pants about dental trauma, because we're usually the first line where patients come to, and we have to be able to know how to help our patients when they come to us. So avulsed teeth is a common injury that we see, especially with younger children. If we have a tooth that comes out, if it's a baby tooth, we don't need to worry about it too much. We need to make sure that the patient's stable and that all the debris has been rinsed out. But if it is a permanent tooth, we should try to reimplant that tooth as soon as possible. So if you could reimplant it then and there and kind of keep it in place, that's the best thing to do. If you cannot, if there's a lot of debris, say they fell and they have dirt or things on there, you want to rinse it gently with tap water. You're not going to scrub the tooth or sterilize it, and you should try to reimplant the tooth within 15 minutes. You can, if you cannot get the tooth back in, or if there's risk for aspiration, it's this really small kid, you can store the tooth in milk for a period of time. Another thing I've seen folks do is, especially with tiny like toddlers or things like that, is just take the child to be evaluated, because baby teeth, again, you can't really do much about. If it is a younger kid that you're worried about aspirating that does have a permanent tooth, the parent can actually store the tooth in their buccal mucosa to keep it hydrated until they get to where they're going. I mean, this is if you don't have access to milk and you're far away from a dentist or things like that. Children are accident prone. They also can suffer oropharyngeal trauma like puncture wounds within there, like running with a pencil or popsicle or stick. And really just depends on the extent of the injury. You want to be careful because the internal carotid artery runs in the posterior pharynx, and so if you have excessive bleeding or swelling within this area or trauma, you might need to get a more careful examination to look for bleeding that we can't see with our eyes. And this is just a chart from Up to Date about the different types of internal trauma injury. I've actually seen something really similar to this, but with a straw, where the patient fell and got the straw lodged in the back of their mucosa and their soft palate. Theirs was easily removed without needing repair, but again, you should assess this and get the right specialist on board if needed. Last but not least, something that we mentioned back in the neoplasm lecture is leukoplakia. So leukoplakia is a potentially malignant disorder, whereas you have leuko, white, and plakia, plaques, within the mouth. They're usually patches along the oral mucosa, and these patches cannot be wiped off, as opposed to oral candidiasis, so you have to compare and contrast those two. So with tobacco use, we tend to see some leukoplakia, both the smoked tobacco and smokeless tobacco. Also, alcohol abuse and HPV infections are kind of risk factors for developing leukoplakia. Leukoplakia in and of itself is benign. However, there is a malignant potential of developing squamous cell carcinoma. About 5% will eventually develop it. And that doesn't sound like a whole lot, but it can it can happen, so we do have to keep an eye on it. And if there is what we term erythroplakia, which is kind of a redness of the area, it is a higher chance of having cancer, up to 90%. So we do need to get a biopsy on those. There is another style of leukoplakia that is also called leukoplakia, however it's called oral hairy leukoplakia. And this is completely different than the leukoplakia that we're talking about here. And in that case, it's caused by things like Epstein-Barr virus and HIV-infected patients. This is completely benign. So leukoplakia, like it's in the name, is a flat or raised white lesion that cannot be rubbed off. You often find it on the tongue or in the buccal mucosa. If we have the erythroplakia, remember that is some reddening in and around the leukoplakia, that has a higher risk for malignancy. Most cases of erythroplakia, like I said, are precancerous or already cancerous. You'll want to inspect the mouth. You'll look for lesions that don't scrape off. You also look for surrounding lymphadenopathy. Diagnosis is made by an excisional biopsy to look for signs of cancer or risk for cancer, and to properly diagnose the lesion. So for 2 to 3 circumscribed lesions should have surgical excision. If you have a large area where surgery just would cause too great of a deformity, you can do other things like cryosurgery or laser surgery. You want to remove the removable habits that are precursors, such as alcohol and tobacco. And then complete excision is the standard of treatment for dysplasia or malignancy, so taking out the entire area. We can have up to a 30% recurrence rate, and so we do have to continue to monitor even after that area is removed. For oral hairy leukoplakia, it does not have a malignant potential. You can use other things such as zidovudine, acyclovir, things like that, but usually therapy is not indicated. So here's the difference between leukoplakia and oral candidiasis. We got a smoker on this side, malignant potential. It cannot be brushed off, and then this guy can be brushed off when you use antifungals. And then here's the oral hairy leukoplakia. It looks more like hair. And like I said, associated with Epstein-Barr, HIV, and usually painless and benign. And I think this one I put on here, this is oral hairy leukoplakia, and the others are just leukoplakia, which is kind of hard to tell the difference between them. And that's why sometimes when we're in doubt, we get the biopsy. All right, couple of abnormal findings. Oops. As you can see, these tonsils and these tonsils look pretty similar. And there are some little differences, but they look kind of similar. And that's why it's important to get those tests to help guide your diagnosis. This is strep pharyngitis on top. This is viral pharyngitis without tonsils. These are tonsillar crypts, which are benign or can be a normal finding, little holes within the tonsils that can sometimes fill up with food and cause bad breath. And this is mononucleosis or infectious mono. As you can tell, these two look quite similar. So I always tell my patients I can't see, I don't have microscopic vision, so I get the tests to help guide me. Like we said before, these type of illnesses are pretty common to see in the clinic, so it's good to know the major differences between them. If you have problems differentiating, I would go back and kind of read through some of the highlights and try to help in your brain file the different illnesses away and the differences in their presentation and treatment. And that is it. So if you have any questions, reach out to me. Do lots of practice questions to help you know whether you know something or not. And I will see you all in class. Thank you.